Okay, good morning, everyone. Can you hear me okay?
We can hear you, Mark.
Groovy. Bear with me here just a little bit as I'm going to be doing the lecture as well as admitting everybody to the meeting, and hopefully we get everybody in here pretty quick. Dr. Whitwer is out today. He's having a back issue taken care of, so he won't be. He actually had a doctor's appointment scheduled during this, so I'll be doing the PCEP today. If you guys have questions, use the little sticky note chat function, and I'll try and get to them at the end, or maybe I'll pause as we go along and get to the end. Can everybody see my screen?
Yes, Mark.
Okay, perfect. So we'll move on. This month we're gonna do emergencies in children. I've pared this down a little bit. I had previously included Travis Act information in here, but we're gonna do that on a separate thing. So we're gonna focus mostly on emergency issues today. They'll be focused on protocol discussion and how to manage. Most of this should be, well, hopefully all of this will be a review for everyone. So without further ado, we're going to shuffle on. First thing we want to talk about is assessment. The pediatric assessment triangle is a measure of forming general impression of your pediatric patients, and essentially that's noticing their appearance. Number one, how do they interact, their work of breathing, and then their circulation. Appearance, mental status, and muscle tone can give you an excellent idea of the overall sick versus not sick that the child would be dealing with. Immediate information and gross abnormalities. The patient's flaccid, they're having significant work of breathing and or apneic. Those are things that you need to, or shock states. Those are things that you need to intervene with quickly and rapidly. Work of breathing, what's the respiratory rate and effort? Are you noticing retractions? Are they working excessively hard to breathe? And is their breathing work consistent with what their age-related vital signs are? Circulation, what are their skin signs? Are they a color they're not supposed to be? What does their capillary refill tell you? All of these things can indicate what their circulatory status is. And any derangements in those you need to deal with right away. If not, the findings from your PAT assessment, these basically let you know that your patient requires immediate intervention and rapid transport, or can you move further in your assessment? Assess their ABCs, treating life threats, transport as appropriate. We'll talk about appropriate destinations here in just a little bit. If your patient is stable, then you can finish your assessment. Okay, moving on to specific issues. Foreign body airway obstructions can be common in infants and toddlers. Their mouths are kind of like a third hand. They are at high risk for aspiration. A mild obstruction presentation in younger kids. Typically they're awake, they may be drooling, a little bit stridorous. They have an increased work of breathing, yet they're still oxygenating, so they can have good color, may not may not appear in extremis immediately. A severe obstruction, on the other hand, they become cyanotic and hypoxic and can become unconscious. Treatment for a partial obstruction. Sit patient up and try and have them cough. The most important thing is to try and have them expel the foreign body themselves. Less invasive, typically easier for them to do. If the obstruction is not cleared, yet they're still not completely in extremis, be suspicious that it was aspirated. They must be evaluated at that point. In a complete obstruction, use AHA guidelines for a complete obstruction. Laryngoscopy and unconscious. You can attempt to remove the foreign body with a McGill if you have that available to you. If the obstruction is not removed and unable to ventilate, consider needle jet insufflation in young kids. Actually doing a crike in a infant or a toddler is not something that we do pre-hospital. But needle jet insufflation as necessary. You can also attempt intubation and maybe push it down past the carina, past the bifurcation, and help oxygenate them after that. Moving on to croup is a viral infection of the upper airway. It's typically, the onset of this is typically abrupt. The kid appears sick, ill for a few days, may even start to feel like they're getting better, and all of a sudden they wake up in the middle of the night because they can't breathe and they have a croupy presentation. It can, your assessment can present with an alert infant or toddler with, they have audible, they're stridorous, especially with activity or agitation, which croup can cause them to be hypoxic, which is very agitating. They have a barky cough, increased work of breathing. They can have normal skin color. Severe signs are when they start to develop that barky cough. And for those of you who have seen a croupy kid, you'll never forget what that sound and appearance of the child is like. They can become stridorous at rest. They develop intercostal, abdominal retractions with their work of breathing. They develop significant distress and agitation. These kids presenting with impending respiratory failure, they become severely hypoxic. Their level of consciousness becomes depressed. They become stridorous at rest, as mentioned before, severe retractions. They have poor ventilation, poor excursion. They become severely cyanotic, or they become pallorous. These kids are really hypoxic, and you're going to have to create a plan on how to manage that. Oftentimes high flow oxygen, maybe intubation, rapid transport. Epiglottitis, inflammation of the supraglottic structures. The classic presentation is a sick, very anxious kid. They may be in a sniffing position. They may be drooling, whatever they can do to try and maintain an open airway, basically. They have an increased work of breathing. Pallor or cyanosis, as previously mentioned with croup. Epiglottitis is rare, especially now that we can flu immunize kids. Upper airway protocol treatment for kids. If they're stridorous, racemic epi, half a cc and 5 cc's of normal saline, nebulize that, and or mask could be used as well. Usually easier to do that. They don't like to use a tube nebulizer. Half a ml of epi is an alternative if racemic isn't available. Same, it must be nebulized. Smaller kids, less than 20 kilos, half the dose. Same with epinephrine. Treat anaphylaxis and foreign body obstruction per adult guidelines. Anaphylaxis is covered in a different lecture, but use guidelines for foreign body obstruction. If the child deteriorates, ventilate as appropriate. If you cannot effectively ventilate with a BVM, perform intubation, much like we talked about with the foreign body obstruction previously. If a complete obstruction is present and you cannot ventilate them, consider needle crike in these kids. Moving down the respiratory system, asthma, the three main components of asthma: bronchospasm, inflammation, and increased mucus production. I think we're all pretty, we're very savvy in dealing with asthma, especially in our region. The bottom picture basically, on the left-hand side, these are normal bronchioles. During asthma, you can increase mucus production, increase inflammation of bronchi, and then hypertonicity of airway musculature creates air trapping, essentially. The whole goal of treatment at that particular point is reducing inflammation, increasing airway diameter, and oxygenation. Triggers for asthma, allergens, secondhand smoke, cold air, exercise-induced asthma, especially in younger people. Respiratory infection is a trigger for asthma, and stress can also be a trigger for asthma. And treatment, bronchodilation, as we spoke, less than 15 kilos, 2.5 to 5 milligrams, greater than 15 kilos, 5 to 10, so double the dose. Albuterol with Atrovent. Now with kids, you can make this continuous. They tolerate that quite well. The anti-inflammatory is steroid treatment with Solumedrol, max of 125 milligrams. The dose for that is 2 milligrams per kilogram. Decadron is alternative, and that's 0.6 milligrams per kilo if Solumedrol isn't available. And then mag sulfate, 25 milligrams per kilogram. These patients often are hypomagnesic, especially if they're in a status asthmatic situation. And then epi as appropriate via drip for status. Okay, bronchiolitis, most contagious syncytial virus. It typically happens in winter, especially in daycare situations, although I would soon guess that cases of bronchiolitis might decrease with all the COVID precautions, hopefully. Typically happens in younger kids, less than 2. Mild findings or characteristic findings, mild to moderate retractions. They're tachypnic, diffuse airway sounds, typically wheezing and crackles. They could be mildly hypoxic in a milder case of bronchiolitis. Severe cases, increased effort, tachypnic. You'll notice their nasal flaring. They can have retractions, accessory muscle use, and they can start grunting, all in an effort to help them basically sort of auto PEEP. They're trying to oxygenate. SpO2 is typically decreased significantly. Focus needs to be on oxygenating these kids. apnea and acute respiratory failure, and then we deal with that appropriately or accordingly. Appropriately, either one. Acute bronchiolitis in less than a 2-year-old, it's treatment. If they have mild to moderate respiratory distress, blow by O2 if they can't tolerate a mask or a nasal cannula. You want to keep their SpO2 greater than 92% as you can, and then monitor the end tidal CO2. Wheezes, use wheeze medicine via nebulizer. If improvement, you can use that every 2 minutes or continuous if severe. Prepare for positive pressure assistance with a bag valve mask and intubation if they're apneic. If their end tidal CO2 is greater than 55 or inability to maintain an SpO2 of 85%. So if they're hypercapnic, hypoxic, you may have to intubate these kids. Moving on to infectious issues, presentation for pneumonia. In newborns, they can have poor feeding and significant irritability. They can be tachypnic, develop retractions, grunting, become hypoxic. For infants, typically a cough, history of upper respiratory infection, being cold and flu season now, getting a simple upper respiratory infection can manifest or develop into a pneumonia. Signs of that, tachypnea, retractions, they become hypoxic, persistent cough, they get lung congestion. These patients have a fever, they're irritable, just not happy. They also have decreased feeding. With children and adolescents, the infectious process, the common infectious process, signs and symptoms, fever, cough, congestion. They can develop chest pain, dehydration, and lethargy. Chest pain is often pleuritic because they are dehydrated. Management of pneumonia, supportive, get them in a position of comfort. Oxygenation, very important. Maintain an SpO2 greater than 90% as you can. Manage respirations and treat wheezing, PRN as necessary. Use Albuterol and Atrovent as appropriate with that. And then they need to be hydrated. So manage fluids with fluid challenge as appropriate. Whooping cough or pertussis, highly contagious. It's spread through respiratory droplets. Symptoms, the initial symptoms of pertussis are similar to a common cold. Significant bouts of coughing can lead to hypoxic and causing them to be cyanotic. Treatment is supportive. Maintain oxygenation and manage the airway as you can. Little humidified O2 can help. Managing septic shock in kids, the clinical definition is a suspected infection. We've talked a little bit about some infectious processes already. Manifest by hypothermia or hyperthermia. So not all sepsis is feverish. Clinical signs of inadequate tissue perfusion, altered mental status, decreased capillary refill, become mottled, their extremities can become cool, decreased urine output, and then hypotension. Signs of inadequate tissue perfusion and with suspected infection, septic shock. Management is maintain oxygenation. 20 mils per kilogram can repeat by 1 to manage shock with fluids. Maintain fluids to appropriate BP an age-specific blood pressure, or you don't want to put them into pulmonary edema. If the patient is still hypotensive, consider norepinephrine. 0.1 microgram per kilogram per minute as a drip. May increase to a total of 0.4 micrograms per kilogram per minute every 5 minutes. Alternative is epinephrine, an epi drip, 0.1 microgram per kilogram per minute, IV, or you can give either of these, IV or IO. And then notify your receiving facility, just like adults, notify that you have a patient that's potentially in a septic shock. Cardiogenic shock is pump failure due to a congenital defect, which is typical. Well, congenital defects aren't typical, but the cause of cardiogenic shock is typically a congenital defect. They may have a rhythm disturbance. Supraventricular disturbances are most common. A myocarditis due to infection. Other secondary causes are near drowning. Inhalation can lead to this. Signs and symptoms: they're listless, lethargic, increased work of breathing, impaired circulation, mottled or cyanotic, or they can be pale, sweating with feeding, increased work of feeding, especially in infants. And then cardiogenic shock management is previous for any shock state. Fluids, don't put them into a pulmonary edema status, and if they're still hypotensive, then norepinephrine and or epinephrine is appropriate. Seizures in kids. Simple seizures in younger kids, an infectious situation or fever in child age 6 months to 5 years. These are simple seizures, usually a single seizure, generalized, lasting less than 15 minutes, no abnormalities by exam or history. Fever not caused by meningitis, encephalitis, or any other illness affecting the brain. History is important there. Determine were they sick previously. A generalized clonic or generalized tonic-clonic seizure. This is a simple seizure. Complex seizures, age, neural status before the illness and fever are the same as for simple seizures. This seizure is either focal or prolonged, greater than 15, i.e. status seizures greater than 15 minutes, or multiple seizures that occur in close succession. Treatment for seizures in kids. Patient is in status. I think we call those complex now, which is defined as continuous or repetitive seizures without regaining consciousness. 0.2 milligram per kilogram Versed. So Versed dosing IN versus IM versus IV is different. So 0.2 milligrams per kilogram intranasal for kids, 0.3 milligrams per kilogram intramuscular, max of 5 milligrams. Repeat 5 minutes until the seizure stops. If you do have an IV, 0.1 milligram per kilogram IV or IO, max 5. Repeat every 5 minutes until the seizure stops. Monitor the respiratory status very closely, especially, after administering Versed. Febrile seizures are generally found between the ages of 1 and 6, as we spoke to previously, short in duration, and note whether or not they have a fever. Treat with Versed as above. You can cool these patients, the febrile patients, which is greater than 103. Give Tylenol, 20 milligram per kilo suppository. If on initial arrival your patient isn't actively seizing, if they are postictal, IV is not immediately required. If the patient is hypoglycemic or this is a first-time pediatric seizure, even if febrile, patients need to be transported. Bruit is a brief resolved unexplained event. It's an event that lasts less than a minute in an infant, less than a year of age, and it's typically associated with one of the following. They can become their skin, they have skin changes. They become pallorous, cyanotic. They can have absent, decreased, or irregular breathing, marked change in their muscle tone. They become hypertonic or hypotonic. So they can develop an increase or a decrease in muscle tone, altered level of responsiveness, something that scares the caregiver, basically, but it's brief. Treatment, support their ABCs, follow airway management and respiratory distress protocols as needed. Document any complications of previous of their previous history. Were there issues in pregnancy? Is there a congenital anomaly? What was the patient's estimated gestational age at birth? Did it fit with when they were actually born? Were they preemie, et cetera, et cetera? Have they had a fever or recent infection? Also in there, you should note, have they had any recent feeding issues? Have they had a prior bruit? And find out, your history needs to find out whether or not they have any other underlying medical conditions. Do your best to get a good, clear, detailed description of the events. Make sure these are documented, including any resuscitation attempts that were done prior to your arrival. Continued management, they should be monitored. Follow dysrhythmia protocols as necessary. Assess their blood glucose. And then transport to an emergency department. These are ALS patients. Even though the thing with the bruit is that these patients, they have these episodes and can appear quite normal when you first see them. These patients need to be evaluated to rule out any underlying issues. This is an ALS transport. They need to be transported to the appropriate emergency department. Contact online medical control. Oftentimes, the caregiver may feel relieved once the child becomes somewhat normal again, and refuse transport. These patients need to be transported. Use all medical control as appropriate. Basically, essentially, these patients need to go in for evaluation. Bruit is a group of symptoms. It's not a specific disease. They're most common in infants under a year of age. They may occur in kids up to 2 years. By the time you arrive, many of these kids may appear normal. Consider non-accidental trauma, i.e. abuse, in these particular cases. Serious underlying causes can include pneumonia, underlying bronchiolitis, a seizure disorder, or one-time seizure, i.e. febrile seizure, sepsis, intracranial hemorrhage due to congenital issue and or trauma, and meningitis. Most common, these happen in preemies, and then kids that have other underlying health conditions. That's why these kids, even if appearing normal, they must be transported to an ED for observation and further assessment. SIDS, these are young kids, less than 6 months, sudden, may appear without cause, happens during sleep. It may be it's oftentimes impossible to differentiate SIDS from suspected child abuse. Interventions, things you can do in these cases. If you are called, hopefully quickly when this particular when the cardiac arrest happens, CPR, unless there's obvious signs of death, rigor, lividity, follow your protocols for cardiac arrest. Resuscitation can be terminated in a SIDS case only by order of medical control consult, or if there happens to be a family physician at the scene. These are very difficult cases to manage. Most of your job, SIDS SIDS is the definition of a death syndrome itself. Previous to SIDS, you're dealing with cardiac arrest. So you need to be supportive, avoid blame. Note, and this is very important, especially for investigative purposes. Both Dr. Whitwer and I are involved in a local committee through the health department, multidisciplinary committee that looks at child death. And it's very important for EMS to note certain things regarding, especially if you end up treating the case. It's very important to note how what location the child was in, how were they positioned, what objects were immediately surrounding them. Oftentimes SIDS cases are due to sleeping with parents and or a lot of stuff that's crammed in a crib. And note the behavior of adults that are present, any explanations that were provided. What did you note? Did you notice anything in the mouth? Oftentimes these SIDS cases will have what's known as purge. Did they have vomit or blood in their mouth? Was there a foreign body present? And then it's important to document these things and make note that the medical examiner needs to know these things, as well as when you're calling for a medical control consult, make sure that they know this information as well. Injuries in children, moving on into traumatic situations. Injury mortality surpasses deaths from all other causes in kids. Their anatomy and physiology produce distinct injury patterns and the mechanisms, and we'll get into that a little bit further. Mechanisms are related to age and stage of development, and we'll talk about the differences in that shortly. Neuro and respiratory derangements far exceed hemodynamic derangements. We'll talk about that as well. They have a larger head and smaller jaw. They have a shorter, narrower, funnel-shaped airway. Kids also, especially younger kids, have a softer cranium. Their fontanelles haven't fused as of yet. Prominent occiput, when you're thinking of immobilization and thinking of airway control with kids, their occiput is often prominent. So it works out much better to prop the shoulders to keep them in cervical alignment and or maintaining their airway. So you want to put them into an anatomically neutral position. Oftentimes the best way to do this is to prop under their shoulders. Their cervical spine is flexible. Their ligaments aren't as well developed. Wedge-shaped, anteriorly wedge-shaped vertebrae. Once again, that goes back to airway control issues and maintaining a neutral position. Flat facets. Angular momentum forces can create a pseudosubluxation and you may not, this may even be difficult to pick up in during imaging. You notice these things by their signs and symptoms. Their chest is soft, pliable. So if they have broken ribs, it takes a pretty severe impact to make that happen. They have weak intercostal musculature. Tension pneumothorax is poorly tolerated in kids. Their abdomen is softer, thinner, not as well protected. Their musculature is not as well developed. Their spleen and liver are lower riding typically. The bladder can be further up into the abdomen, higher riding bladder. Multiple abdominal, combination abdominal chest injuries are common when kids have a thoracic blunt mechanism and or penetrating. Physiologic impact of trauma. Kids have age-specific vital signs. They have a smaller circulating volume. They have a decreased functional residual capacity. Vigorous compensatory response. They respond meaning basically they can respond to an insult and then they deteriorate quite rapidly. They have a limited reserve, and as I mentioned, they can deteriorate quite rapidly. So kids that have sustained a significant mechanism, you have to have a heightened suspicion, even if they appear relatively hemodynamically stable. Be prepared for them to deteriorate. Prevent hypothermia in kids with trauma. I know we speak in a primary survey typically, and getting into the secondary surveys to expose these kids, but make sure you maintain their body temperature. They lose most of their temperature through their heads. So just be cognizant of that and maintain body temperature with these kids. Be alert to suspicion of child abuse, especially in younger kids that have sustained trauma that may not be explainable. The mechanism of injury and their presentation and the explanation of same is conflicting. Be suspicious of injuries that don't look right. Things like small circular burn marks, multiple bruising in various stages of healing, belt marks. Children with history of repeated injuries, i.e. this is a scene you've been to before, and or the caregivers, others present repeat previous issues. One of the bystanders starts blaming others for the injuries that the child has, or procrastination in seeking aid, i.e. the injury or issue happened, a long time previous, or just something that's not commensurate with what you're seeing in front of you. There may be sexual abuse involved in that as well. Treat injuries per protocol. Transport without delay for any critical cases back to our assessment triangle. If there's issues with appearance, work of breathing, their activity, then these kids need to be transported quickly to an appropriate facility. And then once you document as carefully as possible the caretaker's descriptions of what happened. Note the environment, including the temperature. Was it appropriate for the time of year? What was the reaction of the adults, including others that were on scene? What were the note the clothing, stains, and conditions. If you can, bring the clothes with you. Encourage caretakers to allow transport of the child to the hospital if they attempt to refuse. These kids need evaluation. And then if you suspect something very suspicious, notify law enforcement, medical control as well as necessary. And then if these kids if you're able, support and reassure them. Oftentimes they can be pretty freaked out by adults. Don't be judgmental, supportive to the family's concern. Okay, infant and child death scenes. Note the previous for child abuse. If the appropriate agencies, i.e. law enforcement and/or the medical examiner, aren't on scene, make sure that you notify them. Document the following. Most of this we've already noted and discussed. Note the position when originally found. What was the position of the face? Was it covered by stuff? Was there a bunch of things in the sleeping area? Were they sleeping alone? Like I said previously, oftentimes in cases the infant may be sleeping with a parent or sibling. Do you notice any secretions in the bedding and any treatments that were done previous, i.e. CPR, etc., airway management procedures? Be confident or cognizant of evidence preservation. Remember, this is a child death scene. Do your best to preserve evidence. Obviously, resuscitation takes precedent. Take special care to document all attempts at invasive procedures that you did, including IVs, IOs, airway maneuvers, CPR, etc. Management of trauma. Now this is one of our operating procedures regarding receiving facilities for pediatric trauma patients. So trauma diversion to a pediatric level 1 if they meet criteria, which is at Emmanuel or OHSU. That's where these kids need to go. Unless you need initial airway control, vascular access for resuscitation, or the patient's in arrest, and they meet transport criteria, you can divert to the closest facility. But otherwise, these patients go typically to Randall because it's the closest facility. For long transport or traffic issues, consider activation of the helicopter. You can also rendezvous at Peace Health Southwest as you feel appropriate. That's an option that's available. We'll quickly go through special healthcare needs. We just have a few slides left. Managing kids with tracheostomy tubes who may or may not be on a ventilator. The most common issues with these particular cases are the tube gets obstructed with secretions. Assess the tube position, suction. You may need to remove and replace it. Oftentimes these kids will have a replacement or a replacement tube close by. The parent or caregiver is usually pretty, hopefully, savvy on how to take care of these kids, so use their help as necessary. But most often with a tracheostomy issue, it's a plugged tube. So be prepared to suction and or replace the tube. Gastrostomy tube, issues with those. This is a tube that's directly placed into the stomach. As the name implies, it's used for nutrition and may be used for medication administration. Typically, it's supportive in if there's an issue with whether the tube becomes dislodged or plugged. It's typically not an immediate emergency. The child needs to be transported for management of the tube to replace it or clear it. Central venous catheters, oftentimes placed in the right anterior chest, used for long-term IV access for medications, typically placed into a large central vein. Complications with these are infections. It can be dislodged or broken. There may be an obstruction with this. Once again, these kids need to be transported. If there's hemorrhage associated with that, obviously that needs to be treated. immediately, but these kids are transported for management of the catheter itself. Ventricular shunts are kids that are hydrocephalic. These are placed into the ventricles of the brain. There's typically a reservoir or pump involved with this, and then there's the shunt oftentimes will exit the abdomen. These kids can present as CF fluid accumulates, resulting in a worsening of their hydrocephalic state, become altered, etc. These kids, these are emergent situations, and they need to be taken to an appropriate facility that can manage their ventricular shunt. The infections as well, they may appear septic. They need to be transported for neurosurgical evaluation. And then you need to perform continuous monitoring during transport and treat their specific issues accordingly as per protocol. Okay, last thing that I wanted to mention, under the Universal Patient Care Protocol, and this is page 17, and this was a new addition in our 2019 major protocol changes. Key considerations is that medications that we administer to geriatric patients, and that's currently defined as age greater than 65, and in patients with chronic renal failure, renal disease, they're on dialysis, or they have chronic liver disease, any condition that prevents absorption clearance, we need to consider using the low end of the dosing scale on these patients. We've had a few anecdotes recently of geriatric fall patients that meet trauma entry criterion and trying to manage their pain. Their pain becomes managed quite appropriately on scene, but by the time they get to the hospital, they're pretty well gorked, requiring admission and long-term management. So one of the key considerations is to make sure that we use the low end of a dosing scale when managing these patients. Okay. So if any of you all have any questions, you can make note in the little chat box there. Let's see. I see Dr. Gadbois, and I can't tell if Marlo's on. If you guys, do either of you have any comments or suggestions? Okay, well, hearing none, thank you all for coming. Like I say, if you have any questions about any of this, you can actually even pop me an email, and we'll get to it. And hoping that Dr. Whitwer has a quick and speedy recovery. Thank you all for coming. Have a good week.
Thanks. Allow, cancel, hang on.